Hi, my name is Sandra Allison, and I'm from Washington, D.C., and I will be lecturing you about sonography of the shoulder and elbow. I have no disclosures, and my objectives are to discuss common pathology associated with shoulder and elbow pain, as well as review sonographic appearance of normal and abnormal nerves. So when imaging the shoulder, I'm going to discuss particularly the painful shoulder, and I will be focusing on rotator cuff and rotator cuff tears, tendinosis involving the rotator cuff, as well as issues involving the biceps tendon. And for the purposes of time, I will not be discussing joint effusions or other effusions such as bursal effusions in the shoulder. Now, the normal appearance of the rotator cuff we see here on this short axis and long axis view of the cuff. A normal tendon is hyperechoic or very echogenic. You can see the fine parallel white lines, which are the echogenic fibrils. The surface of the tendon is convex, and the underlying bony cortex is smooth. Here in the short axis view, again, we see a smooth humeral head cortex. We see the rotator cuff in one layer, and then moving on, this is the deltoid muscle here, and then the subcutaneous tissues. Now, for full thickness tears, we will be looking for complete absence of the cuff or a defect extending throughout the cuff. The defect is typically hypoechoic and may be filled with fluid. Sometimes you don't see the fluid, but rather there'd be an area of volume loss which can be accentuated by compression. Sometimes you may see fluid in the subdeltoid bursa as well as within the biceps tendon sheath, oftentimes in the acute setting. Now again, here we're looking at the rotator cuff. This is a long axis view and a short axis view, and if we're looking at the layers of at the shoulder, this is the subcutaneous skin and tissues. Here is the deltoid, and here is the rotator cuff with a defect that is hypoechoic. You can see that this fluid is extending into the subacromial subdeltoid bursa and outlining the free edge of the tendon. And here there's a little bit of irregularity on the greater tuberosity of the humerus where the tendon inserts. The short axis view, we see again fluid filling a defect. Here we see rotator cuff and rotator cuff. This area of the rotator cuff is missing. One caveat is to not confuse this layer, which is the cartilage layer, with a portion of the cuff and call this a partial thickness tear. Again, moving on, this is the irregular appearing humeral head cortex. Here we've got the deltoid, subcutaneous fat, and skin. Now, sometimes the fluid is not anechoic or may contain echoes, either because of blood or debris. And in this case, here we see this is a short axis view of the rotator cuff. Here we see intact cuff, but in this area, we are missing a portion of the cuff. If we're not sure, you can accentuate this defect or evaluate if this is a full defect by compression. Overlying this is the deltoid, the subcutaneous tissues, along with the skin. This is the biceps tendon over here. This is a comparison normal view where you see again the full cuff extending across the humeral head and covering that head completely. Now here's a patient who had presented with long-standing weakness with abduction of the arm. And if you're going to count the layers as we have been doing in the prior slides, we've got the skin here and the subcutaneous fat. We have the deltoid muscle overlying over here. We have the humeral head, and then you can see we are missing that typically seen hyperechoic rotator cuff. In this case, this may be a synovial thickening of the residual subacromial subdeltoid bursa, maybe a small amount of fluid, but in essence, we are missing the entire rotator cuff. This is a full thickness rotator cuff rupture. Now, the same rules apply if you're evaluating a patient with a replacement. In this case, we are looking at the skin and subcutaneous fat. We've got the deltoid muscle here, and this hyperechoic structure with some dirty shadowing is the humeral head component of the shoulder replacement hardware. And you can see again that we are missing that other layer that typically covers this hardware, which is the rotator cuff, also full thickness tear involving a patient with total shoulder arthroplasty. Now with partial thickness tears, again, it may be hypoechoic or mixed if there's debris, or may even look hyperechoic depending on how you're imaging the patient. And the tear may be either on the bursal side, which is more superficial, or on the articular side of the cuff. This is often associated with underlying bony irregularity, as with the full thickness tears. And when describing this in your report, you should include the location, for example, which tendon is involved. Is it the anterior or the superior portion of the tendon? The percentage through the cuff thickness, whether it's 50% through the cuff or less than 50% or 25%, and then the width of the tendon that is involved. Okay, so here we are moving along looking at a bursal surface tear. We're looking at the skin and subcutaneous fat. We've got the deltoid muscle. Here we've got the rotator cuff with a small hypoechoic defect along the bursal side of the cuff. Here we're looking at the underlying humeral head. If you're not sure whether this is pathology or if this is debris, or to further evaluate the degree of cuff involvement, you may compress onto that defect and see if you can splay apart the free edges of the tendon. But again, you can see that there is a area where the cuff is missing here. This is a bursal surface tear, and there's even a little bit of fluid here in the overlying subacromial subdeltoid bursa. Now, when the tear is on the other side, it is called an articular surface tear. So here we see a hypoechoic or anechoic defect in the tendon that does not extend all the way through. In this case, the bony irregularity is minimal. This is an articular surface tear involving the rotator cuff. Now, sometimes the tear is within the substance of the tendon, and that can be called an intrasubstance tear. And here we see these linear hypo to anechoic defects within the tendon extending throughout the substance of the infraspinatus tendon in this case. One more example showing abnormal on this side, the right side, and normal on the left side. This patient presented with acute shoulder pain, long axis view on top. Here we have the rotator cuff with a defect, overlying deltoid, and then the rotator cuff that's normal, extending all the way across the humeral head and inserting onto the greater tuberosity. Short axis view, the supraspinatus is missing, the infraspinatus remains. Here is what it looks like on the normal intact side, where we see a complete cuff covering the humeral head. Moving along to tendinosis. Now, with tendinosis, the tendon is thickened and heterogeneous. You may see some nodular hypoechoic or even anechoic areas. Over time, calcifications may develop within the tendon, which then can lead to interstitial tears or splits, as I showed earlier. The presence of increased Doppler flow is variable depending on the patient and whether the problem is acute or chronic. Now, this patient presents with pain with overhead reaching. We're looking at the supraspinatus tendon in this case, and you can see that the tendon is heterogeneous. It is hypoechoic compared to a normal. We've lost the normal fine parallel echogenic lines, which represent the collagen fibers, and we have this focal area of decreased echogenicity right here overlying the greater tuberosity. Now, if you're not sure whether this is a tear, you may compress on this area to see if you can find a convexity or flattening of the contour of the tendon, or you may rotate the transducer or rock the transducer to bring out any potential anisotropy. And here we have a little bit of fluid in the overlying subacromial subdeltoid bursa, but this is a case of tendinosis involving the supraspinatus tendon. Now, with tendinosis, the tendons are thickened, and there may be compression of the tendons and the overlying bursa between the greater tuberosity and the lateral edge of the acromion process, or even the coracoacromial ligament. And this manifests as pain, sometimes while sleeping, but also with overhead reaching, which extends toward the outer deltoid. It has the same symptoms as plain tendinopathy, and patients may sometimes present with atrophy of the muscles of their back, top and back of shoulder. So here's another tendon that is significantly thickened. It's hypoechoic and heterogeneous. The underlying bony cortex is irregular. And we see nodular hypoechoic areas within the tendon. Sometimes over time, you may see focal hyperechoic deposits within the tendon, which may represent calcifications. And you can see here is the overlying acromion, which may impinge or compress onto the tendon when the patient is abducting their arm. Now, one can test for this dynamically. You can have the patient abduct their arm and watch it in real time. These are stills, but here is the right arm with the arm in abduction, and you can see that the rotator cuff has slid pretty much completely underneath the acromion, whereas on this side the patient is unable to abduct completely because there is thickening of the overlying bursa, and sometimes at real time you can watch this bunching up or ratcheting as it is trying to slide underneath that acromion. Here's another patient who presents with symptoms of pain at night and pain with overhead reaching. Here is the acromion, possibly with a small spur. We've got the humeral head and we've got the supraspinatus tendon. And you can see that there is focal thickening of the tendon due to the presence of calcification within the tendon. And when the patient tries to abduct the arm, the tendon is unable to slide completely underneath the acromion due to impingement and blockage from this intratendinous deposit. Now, sometimes the deposits within the tendon may be paste-like, and this is also another form of calcific tendinosis or calcific tendinitis, as it's called, and these patients may present with acute shoulder pain and decreased range of motion. In this case, you can see this deposit that almost looks like it's on the superficial or on the surface of the subscapularis tendon. It may appear very hyperechoic with not much shadowing, and it may be abutting or tenting the overlying bursa. This is the long axis view, or the short axis view, I'm sorry. This is the biceps tendon, and here it is, the long axis view of the subscapularis tendon sitting right on its surface, abutting the subacromial subdeltoid bursa. Now, over time, that deposit may evolve in its appearance, and the center may become more hypoechoic to anechoic with posterior acoustic shadowing. This is another case of calcific tendinosis involving the infraspinatus tendon in this case. And here we have that deposit in long axis view. Moving on to the biceps tendon. Now that we know what tendinosis and tendon ruptures look like, we can apply that knowledge to other tendons in the body, in this case the biceps tendon. Here is the normal biceps tendon in short axis sitting in the bicipital groove. We have the lesser tuberosity and the greater tuberosity. The subscapularis tendon is over here and the overlying deltoid. In long axis, we have the humeral head with the biceps tendon as it's going through the groove and extending distally, and then the overlying deltoid. Now, one other pathology to discuss with the biceps tendon is that at times it may either dislocate or sublux out of its bicipital groove. Okay, so now we have another patient with anterior shoulder pain, and we can see that the biceps tendon has lost its normal hyperechoic appearance. In this case, it is thickened, hypoechoic. There is increased flow to this tendon on Doppler imaging. In the long axis view, we see that the tendon is hypoechoic with nodular areas. Also, again, with increased vascularity, this time on power Doppler imaging. And more importantly, the patient will report that their tenderness is right in the area where you're scanning when you're scanning this tendon. Sometimes the tendon sheath may distend with fluid, such as in this case. Here is the biceps tendon, possibly with a hypoechoic or nodular area, and fluid and possibly debris within the tendon sheath. In long view, you can see the hyperechoic collagen fibrils and some loss of architecture with nodularity within the tendon and fluid in the tendon sheath. This is biceps tenosynovitis. The tendon sheath may become thickened, may develop webs or adhesions or synechia, and the fluid may not always be simple, but sometimes complex. And here you can see this tendon again with some loss of architecture and thickening of the tendon sheath. If you use power Doppler, you will see increased vascularity in this patient who has biceps tenosynovitis. Now, when you see fluid in the biceps tendon sheath, the first thing you should think of and look for is a rotator cuff tear or rotator cuff pathology, whereas primary biceps tenosynovitis, such as in the setting of rheumatoid arthritis, is much less common. Now, sometimes when you're looking at the bicipital groove, you just simply will not see the biceps tendon. In this case, you may suspect a biceps tendon rupture. You can confirm this by looking inferiorly and following the long head of the biceps muscle to see a free edge of a tendon, or in this case, when it's chronic, it may often be difficult to find the tendon. But you can see that the greater tuberosity and lesser tuberosity have an irregular surface, sometimes can be seen with arthritis, but also with underlying tendon pathology. Now this patient presents with shoulder pain, especially with external rotation. And I'm comparing a normal biceps tendon. Here you see the normal tendon sitting in the bicipital groove. And in this case, we're looking at the tendon which is no longer sitting within the groove, but rather displaced medially, which is the most common location for biceps tendon subluxation or dislocation. When you see the biceps tendon dislocated medially, you should take care to look and see whether there is an associated subscapularis tear, as the tendon may dissect within the fibers of that subscapularis tendon. Moving on to the elbow, it is useful to divide the elbow into compartments, the anterior, lateral, medial, and posterior compartments. Unlike the shoulder, in which pathology may present over the deltoid or posteriorly or extending anteriorly, in the elbow, when the patient presents with pain in a specific location, usually the pathology is in that compartment. It directly correlates with the pain when you're doing the examination and when you're scanning the patient. And you can tailor your examination to specifically address that clinical question because you know you can localize it to that compartment. Now, in evaluating for medial elbow pain, the two most common structures we will be looking at is the ulnar collateral ligament, which is labeled number 4 here on this diagram by Dr. Netter, or the common flexor tendon, which inserts on the medial epicondyle and is represented by this white structure under the arrow. Here are what those normal structures look like with ultrasound. Here is the ulnar collateral ligament, this hypoechoic band, relatively hypoechoic band that is extending across this joint. The common flexor tendon is superficial to that, and you can see it extending onto the medial epicondyle. Here you see the tendon with the fine parallel echogenic fibers or white lines, and here we're looking at the myotendinous junction as it extends into the muscle. Here's another view of that tendon, but you can see that it fans out over a wider area of insertion, just like you see in this diagram over here. Now, for a partial or a tear involving the ulnar collateral ligament, we will be looking at the deeper portion of that complex, and you can see that there is a defect in this ligament right here with the remaining portion of the ligament sitting in this location. Now, for this patient, he presented with medial elbow pain, and you can see that there is a calcification in the expected location of the ulnar collateral ligament. And in this case, this patient was a javelin thrower during his college years, and this is the chronic appearance of long-standing tear or injury to that ulnar collateral ligament. Now, medial epicondylitis, which is a misnomer because it is actually not inflammation as the itis implies, but rather tendinosis involving the common flexor tendon, which inserts on that medial epicondyle. It is also known as golfer's elbow. You may see degeneration within the tendon, just like I showed with a rotator cuff, where there is heterogeneity of the tendon, thickening, nodular hypoechoic areas, or loss of normal architecture. You may see some swelling or redness on inspection, and this will directly correlate with the site of pain. Again, to remind you, we are looking at this white structure on this diagram, which is the common flexor tendon as it's inserting onto the medial epicondyle. These are the normal structures. And in this comparison, patient presenting with medial elbow pain, you see that that common flexor tendon is hypoechoic and thickened with nodular areas of decreased echogenicity, possibly with some punctate echoes within the tendon. With Doppler, you can see that there is increased flow within that tendon, and more importantly, the patient will say this is where they are experiencing their symptoms. This is the normal comparison, medial epicondyle and common flexor tendon. Another case, patient presenting with medial elbow pain. Again, you can see there's some normal tendon here, but this portion of the tendon is hypoechoic. There may be a little bit of adjacent fluid, but in this case, there's increased vascularity in the power Doppler. We don't see a discrete tear, and this is another case of common flexor tendinosis or golfer's elbow. One last case, in this case, more to illustrate that the underlying cortical surface at the medial epicondyle may appear irregular, and you may see calcification in the tendon in the chronic setting. Moving on to the lateral elbow, Structures that may be involved include the common extensor tendon, which is this structure right here, the lateral collateral ligament complex, which is a deeper structure. You may have pathology involving the radial nerve and its motor branch, the posterior interosseous nerve. And these are other lateral structures that I won't be covering for this lecture. So lateral epicondylitis, now that we've reviewed medial epicondylitis, it is the same appearance, but now involving the common extensor tendon as it inserts on the lateral epicondyle. This is also known as tennis elbow. There may be tenderness to palpation, and when you're scanning the patient, they will confirm that you are looking at the area of symptoms. And again, as with any kind of tendinosis, you will see tendon thickening, a heterogeneous appearance to the tendon, possibly with hypoechoic areas, and possibly increased vascularity on power Doppler. We are looking at this structure over here, which is the common extensor tendon. We see that there is some loss of architecture here, decreased echogenicity. In this area, there's disorganization or loss of architecture and increased vascularity on power Doppler, and this is a patient with lateral epicondylitis. Now in this case, if you look closely, you can see hypo to anechoic defects within this very heterogeneous tendon. There's calcifications or an enthesophyte here on the lateral epicondyle and some increased vascularity on power Doppler. So this is lateral epicondylitis or tendinosis with interstitial tearing. Sometimes the tear may be focal, and you can report a partial tear, but you can see there's a defect in this tendon which also appears irregular, hypoechoic, and heterogeneous with increased vascularity and power. And just to show you the normal tendon here is extending over and inserting onto the lateral epicondyle. The deeper structure right here is the radial collateral ligament, which you can sometimes evaluate for tear or injury. Here's another view of that lateral ulnar collateral ligament or radial collateral ligament. It is deep to the common extensor tendon, and in the setting of a tear, you will see a defect in that area, possibly with fluid. This in this image that is provided by Dr. Nazarian. Here's another patient who presents with lateral elbow pain, and you can see that the overlying common extensor tendon is intact, but there is fluid and the free edge of a torn radial collateral ligament. Now, sometimes patients with lateral elbow pain have a normal common extensor tendon, but rather have pathology of the posterior interosseous nerve. The posterior interosseous nerve is the deep branch of the radial nerve. So here we've got the radial nerve coming down the arm, around the spiral groove of the humerus, coming around and then dividing. The superficial branch is right here, which is the sensory branch. And then we have the deep motor branch, which dives between the deep and superficial heads of the supinator muscle underneath the arcata frosch. And this is the posterior interosseous nerve, which may be compressed as it dives into that location. Here is a comparison image of a patient who presents with lateral elbow pain. On the right, we have the normal posterior interosseous nerve depicted in long and short axis and indicated by the orange arrows. So here we've got the nerve extending down, and then piercing the supinator, we have a superficial and deep portion of the supinator and the nerve as it inserts. Here's what it looks like in short axis. In comparison, on this side where the patient is feeling the pain, you can see that that nerve is thickened, and you can see that it's thickened proximal to where it pierces that muscle. That is a classic appearance for nerve entrapment or nerve impingement, and in this case, a patient with impingement or entrapment of the posterior interosseous nerve. Anteriorly, we can look at the joint recesses for effusions. We can look at the biceps tendon, the distal biceps tendon as shown on this image, for rupture, tear, or tendinosis. We can look for fluid in the bursa, look for nerve pathology, either involving the median nerve or the lateral antebrachial cutaneous nerve, or look at the muscles in this location. For the purpose of this lecture, I will be discussing the biceps tendon. So the biceps tendon is a little bit harder to see in this location, mainly because the tendon does not assume a parallel course to the transducer, but rather it dives deep as it inserts onto the radial tuberosity, and therefore we don't see those normal collagen fibers that well. The tendon also normally fans out at its insertion, which should not be confused with pathology. Now in this case, patient presents with anterior elbow pain. Just to show you on this Netter diagram, here is that tendon coming down and inserting medially along the radial tuberosity. Because it inserts medially, it may assist you in your evaluation to have the patient supinate their arm to bring that edge out. Now here we see the biceps, or the distal biceps tendon coming down. It looks relatively normal in its appearance up here, but as it comes down, you see that the tendon appears thickened and hypoechoic, and there's a small amount of fluid where it is torn off its insertion from the radial tuberosity. This patient experienced a sudden pop while at his karate class. You can see a comparison normal distal biceps tendon as it's coming down and inserting onto the tuberosity. And in this side, the affected side, you see the tendon coming down, becoming thickened and redundant as it is partially retracted from its insertion, which is down over here. So here is that free edge of this distal biceps tendon, which has pulled off the bone in this complete distal biceps tendon rupture. Posteriorly, we'll be looking at the triceps tendon, which is this structure right here. You can also look at the posterior joint recess for fluid collections there or within the Olecranon bursa. And we can also look at the ulnar nerve for evidence of ulnar nerve entrapment in patients who present with posterior medial elbow pain. Now that we've reviewed several cases of tendinosis, you can apply that concept to evaluating the triceps tendon. In this patient with posterior elbow pain, we have the triceps tendon coming down, inserting onto the olecranon, but we can see that there is a decreased echogenicity in a portion of the tendon. The tendon is heterogeneous with hyperechoic deposits or calcifications within the tendon and an osteophyte forming from the olecranon process. And this is a case of enthesopathy or insertional tendinosis of the triceps tendon. Now, with nerve entrapments, the ulnar nerve can be entrapped as it enters or extends through the cubital tunnel. These patients present with medial elbow pain and symptoms extending to the ring and small fingers. The entrapment may occur at the level of the medial epicondyle as it enters the cubital tunnel, or may occur as it exits the tunnel and pierces the flexor pronator aponeurosis. The ulnar nerve is seen here in ultrasound extending through the cubital tunnel and piercing between the flexor pronator muscles. Here is what it looks like in short axis. Just to give you a reference, here is the Netter diagram of the ulnar nerve as it extends along the posterior medial elbow behind the medial epicondyle and extending as it pierces underneath the flexor pronator muscles on this view. So the nerve can be enlarged greater than 9.5 is the cutoff that some people use in terms of cross-sectional area, but here you can see you can trace the nerve and measure it. This is a patient who presented with medial elbow pain. The ulnar nerve was enlarged. Just for reference, this is the medial epicondyle. And in long axis view, you can see a focal waist or focal narrowing of that ulnar nerve. Typically, when a nerve is pinched, the nerve proximal to the site of entrapment will become thickened and hypoechoic. This is a case of cubital tunnel syndrome or ulnar nerve entrapment. Now, patients with medial elbow pain, one thing you may do is evaluate the ulnar nerve for subluxation, especially if the patient is presenting with a snapping elbow. So just to orient you, we are looking here in short axis at the ulnar nerve. This is with the elbow in extension. This is the medial epicondyle and the ulnar nerve, which is outlined here in red. And as they have the patient flex, we will watch to see if the ulnar nerve subluxes anterior to the medial epicondyle, such in this case, where you see now that the ulnar nerve with the elbow inflection is sitting anterior or along the medial epicondyle. Now, fluid may collect in the Olecranon bursitis and present with posterior elbow pain. The Olecranon bursa is indicated here as number 9. It is a potential space or a lined sac, which again can be filled with fluid. This can sometimes be related to trauma, but can also be seen in the setting of gout. And here are some examples of fluid distending that bursa. You can see that it is actually a little bit overlying the triceps tendon, but also extending onto the distal portion or more distal portions of the olecranon. Here is a significantly distended bursa with debris within the bursa. one must take care when they are imaging this area to not overly compress with the transducer as to potentially obliterate that fluid and miss the fluid distending that bursa. And that's it for my review of common conditions that affect the shoulder and the elbow and their sonographic features. And I thank you for your attention.